Welcome to Falcon Physician Reviews for a review of adrenal pathology. First, a review of the basics. You may recall that the cortex is comprised of three zones: the zona glomerulosa, which produces the primary mineralocorticoid aldosterone; the zona fasciculata, which produces the primary glucocorticoid cortisol; and the zona reticularis, which produces the adrenal androgens. The adrenal medulla produces catecholamines, norepinephrine and epinephrine, as well as a small amount of dopamine. Just to review some other physiology, aldosterone is important in mineralocorticoid function, so it stimulates the renal reabsorption of sodium and stimulates the secretion or excretion of potassium. It's important in maintaining appropriate plasma volume. Glucocorticoids have a wide variety of physiologic actions. They also supplement the mineralocorticoid actions of aldosterone, so they're important in plasma volume, maintaining plasma volume and renal reabsorption of sodium. They also have anti-inflammatory effects and a variety of metabolic actions. And the androgens play an important role in secondary sexual characteristics for men. Cushing's syndrome is a form of hypercortisolism. In fact, Cushing's syndrome refers simply to hypercortisolism of any etiology. Specific causes of Cushing's syndrome include exogenous administration of glucocorticoids, and this is in fact the most common. So iatrogenic Cushing's syndrome is the most common. These are primarily patients with rheumatologic inflammatory disorders such as rheumatoid arthritis that are chronically taking small amounts of prednisone or other steroids. Pituitary hypersecretion of ACTH, that's a very specific cause of Cushing's syndrome termed Cushing's disease. Adrenal hypersecretion of cortisol occurs with adrenal adenomas, with adrenal carcinomas, or with adrenal hyperplasia. This is a form of adrenal hypersecretion is a form of ACTH-independent Cushing's syndrome, although you can get adrenal hypersecretion in response to ACTH hypersecretion as well. We'll talk more about that. Then you can have ectopic ACTH secretion, so a sort of paraneoplastic syndrome. Lung cancers and a variety of other tumors can secrete ACTH. Now this is different. This is not Cushing's disease. Cushing's disease specifically refers to an adrenal adenoma hypersecreting ACTH. So what happens to the adrenal glands in these various conditions? With exogenous administration of glucocorticoids, as we said, this is the most common cause of Cushing's syndrome, you get compensatory adrenal cortical atrophy. So if you think about any endocrine feedback loop, you have a hypothalamic pituitary adrenal axis in this case. So the hypothalamus secretes CRH, the pituitary secretes ACTH, and the adrenal glands secrete cortisol. If you exogenously administer glucocorticoids, you will shut off the CRH and the ACTH from the hypothalamus and the pituitary respectively, and therefore you'll get adrenal cortical atrophy. With pituitary hypersecretion of ACTH, Cushing's disease, you will get bilateral adrenal hyperplasia because the ACTH is stimulating both adrenal glands to grow. With adrenal hypersecretion of cortisol, you can have caused by an adenoma, a carcinoma, or hyperplasia. You'll get corresponding atrophy of the opposite adrenal gland, unless, of course, you have bilateral adrenal hyperplasia. Ectopic ACTH secretion, as with Cushing's disease, you'll also have bilateral adrenal hyperplasia. So what are the clinical features of Cushing's syndrome? The clinical features largely mimic the pathophysiologic effects of excess levels of cortisol. Cortisol acts to stimulate fat deposition in various parts of the body. So it stimulates adipose deposition in the abdomen and the back of the neck, so you get an abdominal adiposity and you get dorsal cervical fat pad, which we used to refer to as a buffalo hump. It also stimulates protein wasting. It stimulates muscle breakdown. So these patients have thin extremities. The arms and legs are thin from the muscle wasting. Cortisol is a diabetogenic hormone, so it stimulates hyperglycemia, and in fact, in a substantial fraction of patients with chronic Cushing hypercortisolism or Cushing syndrome, they will get diabetes. Skin changes depend on the etiology. If it's an ACTH-dependent form of Cushing syndrome, then because the precursor of ACTH is metabolized to produce MSH, you can get some bronzing, some darkening of the skin. Abdominal stria can occur from the obesity, as well as you get some capillary fragility related to the excess cortisol. Osteoporosis occurs, bone weakening occurs because cortisol stimulates osteoclasts and therefore stimulates bone breakdown. Psychosis can also occur. So if you've ever prescribed a glucocorticoid such as prednisone, to a patient, you have to warn the patient they can have very vivid dreams, they may be agitated and anxious, and they can actually get a frank psychotic episode. So in terms of what is causing hypercortisolism, you can perform a dexamethasone suppression test. So dexamethasone is a potent glucocorticoid. It's actually about 30 times more potent than cortisol. And what it normally does in the normal person, it feedback inhibits the pituitary secretion of ACTH. So if you can give a low dose or a high dose dexamethasone. Let's take an example of a patient with a pituitary adenoma, a hypersecreting pituitary adenoma. If you were to give them a low dose dexamethasone suppression test, it would not inhibit ACTH secretion from the pituitary adenoma, because the pituitary adenoma has a decreased level of sensitivity to feedback inhibition. But it still can be feedback inhibited at larger levels. So if you administer a high dose level of dexamethasone, you will shut off ACTH secretion from the pituitary adenoma. Now, why is that important? If you're trying to differentiate between pituitary hypersecreting ACTH and an ectopic secretion of ACTH, the high-dose dexamethasone suppression test can be valuable. So if it suppresses in response to high-dose dexamethasone, it's a pituitary adenoma. If it does not, you can be reasonably sure that it's ectopic secretion of ACTH. Dexamethasone, by contrast, does not suppress adrenal secretion of cortisol by an adrenal adenoma or a carcinoma. And as mentioned, it will not suppress ectopic secretion of ACTH. Now we move on to hyperaldosteronism. As we recall, aldosterone works on the kidney to stimulate sodium reabsorption and potassium excretion, and it works largely to ensure an adequate plasma volume, to ensure adequate perfusion of organs. Excess levels of aldosterone can cause hypertension and occasionally can cause hypokalemia. So hyperaldosteronism is a fairly common cause of secondary hypertension. Years ago, they used to think it was relatively rare. 2 to 3% of patients with hypertension would have hyperaldosteronism. Nowadays, they think it's much more common. Perhaps 10 to 15% of patients with hypertension actually have hyperaldosteronism. It can also produce a hypokalemic alkalosis, and you can have a decreased serum renin due to the hypertension. What are the causes of hyperaldosteronism? Primary hyperaldosteronism can be caused by excessive production of aldosterone by the adrenal gland. In Conn syndrome, you have an adrenal cortical neoplasm, and you can also have adrenal cortical hyperplasia causing hyperaldosteronism. Additional causes of hyperaldosteronism include renal hypoperfusion, renal tumors that are secreting renin, that stimulate the renin-angiotensin-aldosterone system. So just to take a step back and review the renin-angiotensin-aldosterone system here. Whenever the kidneys are hypoperfused, regardless of the reason, the juxtaglomerular apparatus secretes renin in response to the hypoperfusion. Renin is then promotes the conversion of angiotensinogen, which is secreted by the liver, to angiotensin 1. Angiotensin 1 travels to the lung and is converted to angiotensin 2 by angiotensin-converting enzyme. Angiotensin 2 stimulates the release of aldosterone from the adrenal gland. It also has many systemic effects, namely it's a potent vasoconstrictor, arterial vasoconstrictor, so it increases blood pressure, and it stimulates reabsorption of sodium from the nephron as well. Moving on to adrenal virilization. This can be caused by congenital enzymatic defects. In some of the congenital adrenal hyperplasias, you have an autosomal recessive defect, and the steroidogenic pathway, rather than making mineralocorticoids or glucocorticoids, the pathway is shunted to produce excess androgens. So you get decreased cortisol, but the real pathology is because of decreased cortisol, you get a lack of feedback inhibition to the pituitary, resulting in increased ACTH and resulting adrenal hyperplasia. This ACTH stimulates increased production of androgenic steroids by the adrenal gland, which results in virilization. The most common cause of congenital adrenal hyperplasia is 21-hydroxylase deficiency. So in 21-hydroxylase deficiency, you have defective conversion of progesterone to 11-deoxycorticosterone by 21-hydroxylase. Symptoms associated with 21-hydroxylase deficiency, you can have a salt-wasting adrenogenitalism. So you don't have synthesis of mineralocorticoids in this condition, and therefore you lose salt in the urine. When you have salt wasting, you can have orthostatic hypotension, and these patients are predisposed to fainting when they stand up. So these patients actually may need to have a high salt diet or to take salt pills to prevent this. Additionally, they may have to take mineralocorticoids like fludrocortisone. Other symptoms of 21-hydroxylase deficiency, you can see hyponatremia, you can see hyperkalemia. In women, you can get virilism as well, and you can get precocious puberty in males from the excess androgens. Moving on to adrenal insufficiency. Adrenal insufficiency can be characterized by symptoms and signs such as weight loss, hypotension, and this will have an orthostatic component. It may have hyperpigmentation of the skin, depending on the etiology, hyponatremia, and hyperkalemia. And these should all make sense if you understand the normal physiology of aldosterone, the actions on the kidney, and the actions with respect to maintaining plasma volume. How do you diagnose adrenal insufficiency? One of the ways is biochemically. In addition to the history and examination, you can try to stimulate the adrenal gland with synthetic ACTH. We call that cosentropin. So you do a cosentropin stimulation test. You measure cortisol at baseline, then you inject intravenously cosentropin, which is synthetic ACTH, and the adrenal gland should respond to ACTH by producing much more cortisol. So you check the cortisol a half an hour and an hour after injecting ACTH. If it increases substantially, then the patient does not have adrenal insufficiency. The adrenal gland is therefore able to respond to ACTH. If it does not increase substantially, then you know you have a problem with the adrenal gland not being able to respond to ACTH. Some causes of adrenal insufficiency. Autoimmune, and this is typically idiopathic in nature. Infection, tuberculosis in other countries, not very common in the United States, but in other countries is one of the more common causes of adrenal insufficiency. Neisseria meningitis is a cause of particular concern because this can cause Waterhouse-Friderichsen syndrome, and we'll talk about that in a minute. AIDS is another cause of adrenal insufficiency. Amyloidosis, sarcoidosis, hemochromatosis. Cancer can metastasize to the adrenal glands, causing adrenal insufficiency as well. Lung cancer is one of the common causes of metastatic adrenal insufficiency. Long-acting steroids are perhaps the most common cause of adrenal insufficiency. And what happens here is patients, often with rheumatologic disorders, taking steroids chronically, chronic exogenous administration of steroids downregulates the hypothalamic pituitary adrenal axis. And so the pituitary gland is not secreting significant amounts of ACTH. And when the patient therefore stops taking steroids, the pituitary gland, for unclear reasons, is not able to pick up the slack quickly and secrete ACTH. It takes several weeks and perhaps several months to fully equilibrate and restore normal function. And for this reason, patients who have been on long-term steroids really need to be tapered slowly to allow the hypothalamic pituitary adrenal axis to recover. As mentioned just a minute ago, Waterhouse-Friderichsen syndrome can occur with Neisseria meningitidis infection. For the purposes of boards, I would think about this syndrome in a college-aged person who comes to the campus physician with a 24 or so hour history of fatigue, fever, and really looks toxic. And if that patient is hypotensive, you have to have a high index of concern for Neisseria meningitidis infection of the adrenal glands. These patients can die. It's quite serious. It's associated with DIC, and if not treated promptly, these patients can die. So how do you diagnose adrenal insufficiency? One way to approach this is in terms of, is the adrenal insufficiency ACTH independent or ACTH dependent? ACTH independent forms of adrenal insufficiency include autoimmune destruction, tubercular invasion of the adrenal glands, medications such as ketoconazole, which inhibit production of adrenal steroids, metastases, sarcoidosis, and some of the congenital adrenal hyperplasias. The ACTH-dependent forms of adrenal insufficiency that we discussed already include chronic steroids. So with chronic steroids, you're not producing, the pituitary is not able to produce significant amounts of ACTH. So there's nothing wrong with the adrenal glands here. They're just not being prompted by ACTH to produce steroids. And then any lesion, tumor, or infection of the hypothalamic or pituitary, the hypothalamic pituitary axis, can also result in decreased ACTH production and an ACTH-dependent form of adrenal insufficiency. So secondary causes of adrenal insufficiency, we've just discussed this, but briefly, disorders of the hypothalamus and the pituitary can cause secondary adrenal insufficiency, and this is an ACTH-dependent form of adrenal insufficiency. Metastatic cancer to the hypothalamus or pituitary, infection, infarction, irradiation. The thing I want to point out here is that hyperpigmentation is lacking because ACTH levels are not increased. So in the ACTH-dependent forms of adrenal insufficiency, you will have hyperpigmentation because of the increased production of MSH. In the ACTH-independent forms, you will not see that hyperpigmentation. Pathology, the adrenal glands will appear atrophied. This concludes our session on adrenal. This concludes our session on adrenal.